So once again, a warm welcome to all of you for our teaching sessions in internal medicine. We are in cardiology. We have looked at the approach to chest pain last time. Today we are going to go into the depth of the chest pain syndromes. This is called the acute coronary syndromes. The first one is the ST segment elevation myocardial infarction, and this is again divided into three parts. First part is pathobiology, reperfusion timelines, and clinical mastery. Number one, master class on ST elevation diagnosis, the signature of myocardial infarction. ST elevation is called the fate line of an individual. The first thing I ask the resident is when he calls me up, what is the fate line like? If the fate line ST segment is elevated, we are in the ST segment elevation, myocardial infarction, a critical. Okay. Then we also navigate through the current guidelines of European Society of Cardiology and American Heart Association reperfusion pathways. Now, synthesize this evidence-based medicine, post-infarct management, and see how we have to improve the outcomes for our patients. Okay. You see, step one, hemodynamic shear stress. What happens whenever there is a shear stress or the flow stress in the vessel wall? There is a fibrous cap here. This fibrous cap opens up and makes the plaque rupture. Once the plaque ruptures, the core of the plaque contents are exposed. The necrotic lipid core ruptures and exposes highly thrombogenic material to the active blood flow. That is most important first event. There is a plaque already. That plaque may be unstable, and due to the shear stress, due to hypertension, diabetes, other risk factors, the cap gets opened up. Once the cap opens up, the necrotic lipid core is there, the LDL rich core, and the macrophages and all of them, they get exposed to the vascular environment, intravascular environment. Then that triggers a cascade of thrombogenesis, a rapid platelet adhesion, activation, and aggregation. The three is platelet adhesion. The platelets get activated. The activated call in for more blood cells, RBC, and all the clotting factors, and form a mixed thrombus. A white platelet core entangled in a red fibrin clot. That is the 100% occlusion. This is T0. That is the time of plaque rupture. We call it as T0. That means the time when the plaque ruptured, the myocardial infarction process is set in, and then the cascade flows until the vessel gets occluded by a thrombus. Okay. Now, so minutes ED arrival, chest pain, compliance with retrosternal pressure, diaphoresis and radiation, the classic elephant on the chest. చాలా బరువు పెట్టినట్టు ఉందండి గుండెల్లో ఎప్పుడూ లేదు అంత వారు. Not a sharp pain, not a localizing pain, but a very dull retrosternal pressure sensation, diaphoresis, sweating, extreme sweating, and the pain is radiating. Last time we have seen, and the ASA guideline update is explicitly shift terminology away from typical, atypical chest pain. Forget about those terminologies. Earlier, we used to teach like that also, 10 years back. Now, you forget the typical, atypical part and come to cardiac, possibly cardiac, and non-cardiac chest pain. Now, what is at stake? T0, that is when the plaque rupture started, T30, T60, T90. The anterior wall is uniquely vulnerable, and for extensive myocardial territory loss, rapidly escalates the risk for severe pump failure, the terminal cardiogenic shock. Suppose the anterior wall is impacted and the ST segment elevation starts, normal cardiac output more than 2.5 liters, compensated in the beginning, then shock comes, that is CI, cardiac index, is less than 2, and terminal less than 1.5, and then the graph goes down and down like that. So you see, by around 60 minutes, almost there is a severe reduction in the cardiac index. Now, you have to tell me what is cardiac index. It's a small exercise for you. I did not tell you now what is cardiac index. You work out and let me know in the group what is cardiac index. It is, I'll tell you at the end. Okay? Now, this is the signature of myocardial infarction. Anterior signature of myocardial infarction. What are the anterior leads? V1, V2, V3, V4 are the anterior leads. V1, V2 are septal, V3, V4 are anterior, and V6, V5 are the lateral leads. Now, when there is an anterior occlusion here to the LAD, left anterior descending artery, what happens? There will be a signature ST segment elevation. This is called a pronounced ST elevation in lead V1 to V4 anteroseptal injury. This elevation will be so profound that sometimes the ST segment elevation may be more than the associated downstroke or the S wave. Okay, and there will be reciprocal confirmation. Whenever we see myocardial infarction, we will see the culprit vessel leads V1, V2, V3, V4 show ST segment elevation with coving and upsloping. And there will be reciprocal changes in the opposite leads. What are the opposite leads for the anterior wall? L2, L3. The highlight is reciprocal ST depression in the inferior leads. Inferior cameras are inferior leads. That is L2 and L3. These inferior leads to definitely confirm acute transmural injury versus a benign early repolarization. If the ST segment elevation is profound, there is no confusion. If it is mild, you may get it confused with early repolarization. The best way to find out that it is not early repolarization but STMI is to look at the reciprocal changes in the inferior leads. This is the teaching point. Now, you see here, what are the guidelines say here? Sorry. Guideline imperative 12 lead ECG must be obtained and interpreted by a competent person within 10 minutes of first medical contact. FMC is first medical contact. Within 10 minutes, you would have taken the history and all the classical vital signs, you would have looked at it. And also important to exclude the big six, which we have told last time, and also the nurse who is assisting you would have recorded the ECG in 10 minutes, and you had a chance to quickly look at V1, V2, V3, V4 for ST elevation, and L2, L3 for the reciprocal depression of the ST segment as shown on this slide. This is a classical acute anterolateral anteroseptal myocardial infarction. Okay. Now, the physiology. You have to look at the two diagrams. See on the left side, the base of the T wave is very wide, as you can see. The peak is there. T wave is upright, all right, but the base is wide. This is called ischemic hyperacute T. Even before the ST segments develop to elevate, we will see hyperacute T. That means it is a very, very early presentation of myocardial infarction. You should not miss this. If you see a very tall T wave is also called the 10th house of potassium. Means when the potassium is more in the body, the 10th will be up. When the potassium is a hypokalemia, the 10th will be inverted. This is a classical teaching. That is, T wave is the 10th house of potassium. T waves indicate hyperpotassemia, hyperkalemia. How do I differentiate the hyperkalemic T wave, a 10th house T wave, with a hyperacute ischemic T wave? The answer is the base of the T wave is very narrow in case of hyperkalemia. Here the base is very wide as 0.4, 0.5 seconds. Whereas in case of hyperkalemia, it will be less than 0.12. or 0.8008. This is very important to differentiate a hyperacute T from a hyperkalemic T. Okay. Now, HS, high sensitivity troponin kinetics. We have last class, we have seen a rapid rise. What is delta? Somebody asked. Delta is the difference between the troponin in the 0 hour to 1 hour, 1 hour to 2 hour. That difference is called delta. Always, whenever we say delta in medicine, it is the difference between the earlier value and the next value is called the delta. Okay, a delta of higher degree, late sustained peak confirms the infarct size and rapid rise. This is the delta there, indicates acute myocardial necrosis. What is the other important thing I will look at? One, the ECG, the ST segment elevation, the signature, the reciprocal inversion in the other leads, T, the hyperacute T as compared to the hyperkalemic T with a narrow base, and 3, the delta of the troponins. A large delta is in favor of myocardial infarction. And fourth important one is focus point of care, ultrasound. Use the ultrasound gun and then put the probe on this one, on the 3 areas in the lateral view and also the 4-chamber view and also the subcostal view. And you see regional wall motion abnormalities. These are the earliest ones to develop progression from hypokinesis to total akinesis in the anterior and apical segments as shown in this is indicative of ST segment elevation, anterior and infarction, anteroseptal infarction. Now, MONA. What is MONA? What you have to do immediately, once you see ST elevation is there, hyperacute T waves are there, we have differentiated from hyperkalemia, there are regional wall motion abnormalities, there is already a troponin which is very high initially, we wait for 1 hour for the delta, because delta we cannot get within 1 hour, but initial values are already high, we look for the delta later on, before that 1 hour is elapsed, you start MONA. What is MONA? Morphine. This can slow the gastric absorption of critical P2Y at 1K inhibitors. What is P2Y12 inhibitor? Clopidogrel. You have given the loading dose of clopidogrel, 300 milligrams. Morphine might interfere with the absorption of clopidogrel. Keep that in mind. Okay. What does it mean? You may have to increase the dose of P2Y inhibitor, the clopidogrel. Okay. Oxygen. Routinely don't put an oxygen mask to every myocardial infarction patient. Not required. Not recommended by the guidelines. Administer only if the SpO2 is less than 90%. Otherwise, keep the oxygen ready, but don't administer. Okay. And this has got two purposes. The patient already is anxious. If you connect him to some oxygen and a mask, he gets further anxious, thinking that he is going to die. Most of the patients, they do not want the mask. But nevertheless, if it is less than 90, of course, you have to give the oxygen. And nitroglycerin. This is not a must. Contextual, that is right heart, inferior ischemia, very, very great caution, because that can produce hypotension. Anterior STMI, for symptom relief, you can give nitroglycerin. And you must have already given, the moment before taking ECG itself, you have given aspirin. The moment somebody comes with a typical symptoms of chest pain suggestive of myocardial infarction, ST segment elevation, myocardial infarction, still to be confirmed by the ECG, but before that, 325 milligrams of soluble aspirin, solaspirin, available as Dispirin, solaspirin. Suppose I don't have soluble aspirin. What do? Take the entry-coated aspirin, powder it, and dissolve in little water and give it. Don't worry, don't go on shopping for a sort of soluble aspirin. Better you always keep a stock, 20 tablets of solaspirin in the emergency room. But if you don't have it, use the ecospirin, 2 tablets of 150 milligrams, triturate them, and then that powder you can give. Now, should I give heparin or not? Yes. Systemic anticoagulation with unfractionated heparin to halt further clot propagation before the wire crosses the culprit lesion. Before the wire crosses the lesion, you would have given already anticoagulation with unfractionated conventional heparin. How much? 5,000 units. Whether you give intramuscular or subcutaneous, the result is the same. What I will do? Morphine, caution, gastric absorption of clopidogrel, oxygen, not for everyone, only if the SpO2 is less than 90, nitroglycerine to relieve the pain. But be cautious in about inferior infarctions because of hypotension. Anterior infarction you can give if the pain is not relieved. Aspirin must have been given already. What aspirin? Soluble aspirin. Heparinization must have been done with unfractionated heparin. These are non-negotiable treatment parameters. There is no second thought about that. Now, FMC, first medical contact, within 90 minutes. Is there a primary coronary intervention? PCI is primary coronary intervention capable center. Can the patient be shifted there? Or if your hospital is having, within 90 minutes, you must cross the wire across the lesion. That is, the door to wire time, door to crossing time must be less than 90 minutes. Then the outcome is excellent. Or I cannot have a PCI capable center within 90 minutes, pharmacoinvasive pathway. Don't wait. PCI is impossible within 120 minutes. In 2 hours, you cannot reach a center. Then what do? You must administer fibrinolytic agent. FMC to needle must be less than 30 minutes. Now, what did we do? Clopidogrel already given, aspirin given, heparinization done, and then we have also administered fibrinolysis if I am not taking a PCI. If I am able to go to the PCI within less than 90 minutes for the patient, I don't need the fibrinolysis. Then what you do? After giving the fibrinolysis, follow-up mandate, routine transfer to the angiography center as early as possible within 2 to 24 hours. This is the concept of golden hour. Time is tissue, time is muscle. Okay, now where is the lesion? There are 3 blood vessels. Anterior descending artery. This is the anterior descending artery. This is the right coronary artery. This is the circumflex artery. This is called the left main. Left main will bifurcate into anterior descending and left circumflex. This is the RCA, right coronary artery. Is the lesion in the left main or is it in the anterior descending artery, which is the culprit artery? How do I know? Differentiate proximal LAD occlusion versus which jeopardizes a vastly large downstream myocardial territory. The widowmaker. This is called the widowmaker because if the person dies, naturally what will happen? That's why it is called widowmaker. Clinical shorthand for proximal LAD or left main total occlusion. The shorthand, oh, you have got a widowmaker lesion, means the person is going to die and the spouse is going to become a widow or widower. What is that? Proximal LAD or left main disease. What is the fix? Stent deployment restores the TIMI flow of 0 to TIMI flow of 3, normal antegrade perfusion. This stent we have put it before the block. This totally blood is not flowing. Once the stent is opened, the culprit vessel, there is a free flow. This is what you must aim for in within 90 minutes. Now, this is the next medical management will be T plus. That means already time has elapsed. Within 90 minutes, we are dealing the patient. Ticagrelor or prasugrel. These are 2 important drugs. CCU medical management. What do you give? Ticagrelor and prasugrel. These are newer antiplatelet agents. Ticagrelor reversible binding landmark Plato trial has established its role. Proven mortality benefit, ischemia benefit than clopidogrel. So you must switch over to ticagrelor. Loading dose clopidogrel followed by ticagrelor. Key side effect is patient might develop some dyspnea. Prasugrel, irreversible binding compared to ticagrelor, high potency, Trinitron trial, TIMI-38 trial, these have shown it is superior ischemic protection in known anatomy. But prasugrel is absolutely banned in patients who had prior stroke or TIA. Don't give prasugrel to patients who had prior stroke or TIA. Then what is the alternative? Ticagrelor you can give. This is based on the 2023 ESC guideline update, pre-treatment strategies. Routine P2Y pre-treatment is not recommended if the anatomy is unknown. You understand? What is that? If the coronary obstruction anatomy is unknown, that means non-ST segment elevation ACS. You don't have to routinely give these drugs, but remains acceptable in classical STEMI before catheterization. Okay. What is the long-term survival and prevention? What are the long-term drugs when we have to prescribe for this person? This is beta blockers. They reduce the sympathetic drive, lower the myocardial wall stress, prevent the lethal ventricular arrhythmias. AC inhibitors and ARBs are the crucial pillar. They are crucial call-out, mandatory in anterior wall infarcts, level 1 evidence, 1A evidence. Aggressively prevents adverse left ventricular remodeling and dilatation. And high-intensity statins, pleiotropic effects, and plaque stabilization. High-intensity statin must be given. What do we mean by high-intensity statin? Atorvastatin, 80 milligrams, or rosuvastatin, 40 milligrams. Now, what are the drugs we are given? Aspirin, clopidogrel, and then prasugrel. If it is STMI and heparin, already we have given. Nitroglycerin if necessary, oxygen if necessary, morphine to control the pain. And now for the pleiotropic effects of statin, 80 milligrams of atorvastatin or 40 milligrams of rosuvastatin should be given. ACE inhibitors non-negotiable in anterior wall infarction, particularly for left ventricular remodeling. Beta blockers to reduce the sympathetic drive and reduce the arrhythmia and reduce the myocardial demand. Now, acute phase, subacute phase, and chronic phase. The complication horizon, structural complications. What can occur? Acute phase fallout, sudden onset of flash pulmonary edema, heart failure, cardiogenic pulmonary edema due to massive loss of anterior pump function. The pump is not able to function the blood forward, so much so there is stasis of blood backward. That results in acute flash pulmonary edema. This is called the acute flash pulmonary edema is an important complication, acute complication of STMI. The subacute and chronic phase, adverse remodeling occurs of the LV apical part, and the LV apical aneurysm can occur. And once the aneurysm forms, there is thinning and bulging of the dead myocardium. That broods stasis, and that leads to thrombus formation. Intramural thrombus will form. Within the cavity, there will be form, and this thromboembolic risk will be there. Aneurysm breeds stasis, mural thrombus formation requires transition to systemic oral anticoagulation over and above the double antiplatelet. DAPT always is double antiplatelet treatment. Double means clopidogrel, aspirin, or clopidogrel and prasugrel and aspirin, whatever combination we are using. Now we require another drug if there is a LV remodeling and if there is a stasis, if there is already clot there, we are bound to put on systemic anticoagulation, not oral anticoagulation at that stage. Okay? Now, we should be very wary of the electrical complications. Complication horizon, electrical storm, ventricular tachycardia, ventricular fibrillation are the main dangers. Primary indication for immediate defibrillation and amiodarone administration. What do? If I see VT, VTAC or VF, then immediately defibrillation for the VF, and for the VT, we can do defibrillation and amiodarone administration. Now, The other thing that can happen is conduction defects can occur. Anterior MI frequently trigger new bundle branch block. Anterior STMI blocks caused by irreversible structural septal necrosis, high mortality, temporary or permanent pacing will be almost required if they develop bundle branch blocks. Inferior STEMI block, usually transient, driven by the AV node ischemia or heightened vagal tone, and the block gets relieved. But in anterior STMI, the block may become persistent and may need permanent cardiac pacing. Now, the shock trial has taught us that initial medical stabilization, early revascularization. Initial medical stabilization is the red line. And early revascularization is primary coronary intervention or a CABG, coronary artery bypass graft. Either you stent it or do a bypass. They do very well in terms of 24 months survival. In terms of 2 years survival, those who underwent early revascularization, 85% of them survived 2 years. Versus you don't do the revascularization, only give some medications and something like, old order treatment, and you will be almost losing every patient, or only 5% or 10% survive 24 months. These are the survival curves by the shock trial. Really shocking. Cardiogenic shock was once universally fatal. The shock trial proved that early mechanical revascularization vastly improves 6 months and long-term survival. The 2023 culprit shock nonce is, while complete multivessel revascularization is now favored for standard STEMI, in the setting of acute cardiogenic shock, guidelines restrict initial intervention to culprit lesion alone PCI. What does that mean? See, if the patient has presented, he has got LAD, big disease, 90% disease, but he also has got disease in the RCA and the LCAX, then should we treat all the three vessels in the first instance itself, in the primary index presentation itself? The answer is, if he does not have acute cardiogenic shock, you can attempt to relieve all the 3 blocks or 2 blocks. But if the patient is an acute cardiogenic shock, restrict the procedure only to the culprit vessel treatment. And the remaining 2 or 3 or 4 blocks can be taken up at a later stage in an elective way within 1 week or 10 days. This is the teaching. Now, you see here, the clue here is broad symmetric T wave inversion, hyperacute T waves, not hyperkalemia. Okay, hyperkalemia, the base will be narrow. STMI patients with prior TIA and stroke, prasugrel is contraindicated. So looked at the T wave. T waves are broad and symmetric and not narrow like hyperkalemia. And I know it is acute presentation, but I asked the history. No history of TIA, no history of stroke for this patient. Prasugrel is not contraindicated, so I can give prasugrel. Suppose there is TIA and stroke, I give ticagrelor and not prasugrel. The clue is ischemic chest pain, LBP is present. Anybody coming with ischemic chest pain, highly suggestive of cardiac pain, and he has got a new onset left bundle branch block, most likely it is myocardial infarction. Never dismiss left bundle branch block. Apply Garbosa criteria. What are Garbosa criteria? Concordant ST elevation of 1 millimeter, or Smith's modified criteria, ST by following S ratio less than 0.25. This you will see in the subsequent slides. What is the Garbosa criteria? So if you see an ischemic chest pain patient, no classical ST segment elevation, but he has got LBB, don't discharge him, no bundle branch block only, don't throw away. But you apply the Garbosa criteria or Smith's modified criteria and decide in favor of treatment. Clue. ST segment elevation presenting more than 120 minutes away from the PCI center. That means he presented with chest pain. We understood that it is ST segment elevation, myocardial infarction, but the PCA capability is not there. It is within 120 minutes. He cannot reach the place. What you do? Push fibrinolytics within 30 minutes and then transfer. Then treat and transfer. Okay. In the earlier case, what we are doing less than 90 minutes, there itself you do the primary PCI, no fibrinolytics. Now, part 2, RCA, LCX, and right ventricle. So this is the left main, this is the LAD, this is the RCX, and this is the LCX. Decode inferior and posterior ECG footprints. Is it, if it is not anterior, is it inferior wall or posterior wall footprint is there? We have to see. The signature is ST elevation, anterior leads. Execute immediate hemodynamic rescue and avoid preload collapse. Master post-infarct mechanical and electrical complication management. Again, based on the 2023 ESC and AHA guidelines. Now, is it right? It is now we are dealing not with the LAD or the left main, but we are dealing with right coronary or left circumflex. Right coronary will produce inferior infarction. Left circumflex will produce lateral infarction. Right coronary, right ventricle, inferior wall, SCA node, AV node. Left circumflex, lateral, posterior left wall, and minimal right ventricular involvement. Dominance factor, 85% of the patients, right coronary is dominant compared to the left circumflex. Only in 10% of patients, left circumflex is dominant. Remaining 5% of the patients, co-dominant, both right coronary and left coronary. Now, the rhythm disturbances in right coronary artery occlusion. The ECG changes are confined to right ventricle, inferior wall, involvement of a CADAV node. Now, there is sinus bradycardia and Wenckebach's AV block, type 2 AV block, Wenckebach's phenomenon, and then sinus bradycardia will be the rhythm disturbance. Hemodynamic profile, preload dependent RV shock. Whereas in left coronary, left circumflex, less frequent nodal blocks, higher risk of lateral wall irritability and arrhythmia. That is VTAC and something like that can come. LV dysfunction, less sensitive to preload reduction. This is the difference between RCA versus the LCX. Now, Bijold-Jarisch reflex. So, vagal afferents from the inferior posterior wall, efferent parasympathetic surge, bradycardia, hypotension, and vasodilatation will occur. The inferior wall is affected. This is the inferior wall. When the inferior wall is affected, there will be vagal afferents will be going from the inferior posterior wall to the brain. This is the mechanism, and it produces parasympathetic surge causing bradycardia, hypotension, and vasodilatation. When there is hypotension, look at the raised JVP raised or not, whether the lungs are clear or not, auscultate the lungs, and then look for JVP and look for the blood pressure. The bedside crisis, vagal reflexes and RV mechanical shock. If it is RCA, you are in for RV mechanical shock. How do I diagnose? There will be hypotension, lungs are clear, raised JVP, there is a bradycardia, hypotension, and vasodilatation. Okay, now. Inferior segment, inferior ST segment, elevation and physics and reciprocity. What is that? Inferior means lead 3, and then this is the inferior lead 3 and AVF, lead 3, lead 2 AVF will show ST elevation. There will be opposite changes, reciprocal changes in the AVL and L1. L1 AVL showing reciprocal changes. L2, L3 AVF showing classical elevation is an inferior myocardial infarction. What is the diagnostic part? ST elevation magnitude in lead 3 is much more than the lead 2, strongly suggests RCA as the culprit artery, pointing directly to the right-sided injury vector. What I have to do? If L2 and L3 and AVF all show ST segment elevation, is the elevation more in L3 compared to L2? If it is more in L3 lead, it is suggesting of right-sided injury. RCA is the culprit vessel. Okay. Now, V1, V2, V3 we have seen there is not much of a hidden STMI unmasking the posterior infarction. There could be a posterior wall infarction. In that, what will happen? Mathematical axis inversion. The axis is completely inverted here. V7, V8, V9 leads we require, which will show the ST elevation. The 2023 guideline mandate posterior lead for any patient with high suspicion of acute occlusion and isolated anterior ST depression. See, the anterior leads are showing ST depression. What I do? These are actually this ST depression is a mirror change due to the posterior infarction. You can see my website and look at the SES presentations there, and you can find out the ECG, also ECG section also. You can find more details about the posterior infarction. Posterior infarction will have V1, V2, V3, ST depression, and V7, V8, V9, ST elevation. There will be mirror changes in the anterior leads. Then V3R and V4R, highly sensitive and specific for right ventricular myocardial infarction. What you do? Conventionally, we put the leads on the left side. In case of right ventricular infarction, we will put the leads on the right side. They are called the V3R and the V4R, mandated by the 2023 guidelines. So every patient of myocardial infarction, not only record the 12-lead ECG and also record V3R and V4R also simultaneously. Why? To confirm or exclude right ventricular involvement, right ventricular infarction. Now, so the left ventricle here is D-shaped, and then the bowing intraventricular septum will be there, decreased TAPSE, that is trans aortic pressure gradient less than 17, indicating acute or systolic failure. These are the echo findings. Okay, now the hemodynamics teeter-totter preload optimization versus collapse. What is that? The preload is the right ventricle, what the blood receives from the systemic veins into the right ventricle through the great veins, inferior and superior vena cava, and hemodynamic flow model, rigid, non-compliant pericardial slack, pulmonary bed is congested, so that is the left ventricle now feels the pressure. Now what do you do? IV fluid boluses. Maintain high hydrostatic pressure gradient required to push blood through the passive ischemic right ventricle into the pulmonary bed. Right ventricle is not functioning properly, then what you do? Systemic veins and right atrium must be opened with a good fluid boluses. Absolute contraindication, nitrate should not be given, diuretic should not be given. Venodilatation drops the LV preload to zero, causing systemic blood pressure to crash and precipitating immediate cardiogenic shock. In case of RV infarct, IV fluid boluses, avoid nitrates, avoid diuretics to start with. Now, revascularization timelines and no reflow phenomenon. So, okay, 0 minutes, first medical contact, 90 minutes, we have taken him to the primary coronary intervention. Wire crossing the lesion, culprit lesion within 90 minutes, gold standard, 90 minutes criteria, patient capillary bed, like this, microvascular obstruction, there is no reflow. In some patients, in spite of the PCI, they will not have good free flow. That is within 120 minutes. Pivot pharmacoinvasive therapy, fibrinolysis is done first, and then the PCI, bulky RCA thrombus, dislodgement during the PCI clogs the distal microcirculation. Okay, we tried to perfuse the RCA because using within 90 minutes, but then what happened? There is no flow restored. Why? I have dislodged the bulky thrombus into the microcirculation, preventing the tissue reperfusion despite an open epicardial vessel. This is called microvascular obstruction consequent to the PCI. That means no reflow phenomena. Now, angiographic blueprint and coronary dominance profiles. Right dominant 85%, left dominant 10%, co-dominant 5%. We are not talking about LAD. LAD is the main vessel for all the people. For between the two remaining vessels, RCA and LCX, is LCX dominant or RCA dominant? 85% of us are RCA dominant and 10% are LCX dominant, 5% are co-dominant. Because 85% of the human beings are right dominant, proximal RCA occlusions threaten a massive myocardial territory. Right dominant means what? Right coronary artery supplies a major territory apart from the anterior descending artery. Anterior descending artery supplies major area of the left ventricle. But after that, the next important vessel will be RCA, right coronary artery, because 85% of the humans are right dominant. And this includes also critical SA nodal and AV nodal branches also. This can lead to arrhythmias and heart block. Okay. Pre-procedural antithrombotic protocol. What do I do before I submit the patient to the primary PCI? DAPT, that is double antiplatelet treatment. Aspirin plus a potent drug. What is a potent drug? Not clopidogrel, but ticagrelor or pasugrel over clopidogrel. Earlier days, we used to say double antiplatelet means aspirin plus clopidogrel. But if ticagrelor or pasugrel are not available, there is no harm in giving 300 milligrams of clopidogrel. Then for maintenance, you switch over to ticagrelor and pasugrel. Only caution is prasugrel should not be used if there is a TIA or any brain stroke issue. Okay. Anticoagulation, you have started already. That means conventional heparin, 5,000 units. You have given. There are two choices here: unfractionated heparin, conventional heparin, or enoxaparin. In trials, both proved to be the same. Hemodynamic instability. Suppose the patient's blood pressure is falling, bradycardia is there, heart block is there. In the setting of RV-associated cardiogenic shock with impaired absorption or planned emergency mechanical support, avoid subcutaneous agents like LMW or oral loading delays. Prioritize IV unfractionated heparin and consider IV cangrelor to ensure immediate platelet inhibition. This is if there is hemodynamic instability, I don't depend upon subcutaneous drug like low molecular weight heparin. Instead, I give IV unfractionated conventional heparin 5,000 units to be repeated and consider cangrelor to ensure immediate platelet inhibition. This is in patient with RV infarct and RV cardiogenic shock. Now, modifying the GDMT in the setting of inferior valve myocardial infarction and hypotension. What is GDMT? Guideline-directed medical treatment. Guideline-directed medical treatment says three things, three pillars: high-intensity statin, S inhibitors, beta blockers. We have already seen that. Now you have to check now if there is the setting of inferior infarction and hypotension, beta blockers are not indicated. Do not initiate in acute phase of MI, inferior MI with broad borderline blood pressure, overt cardiogenic shock, or active high-grade AV block. Winchback phenomena or Movich type 2, beta blockers are not indicated or rather contraindicated when inferior valve MI, borderline blood pressure, or cardiogenic shock, active high-grade AV blocks like Winchback and then Movich type 2. In all other cases, beta blockers will reduce the sympathetic tone, will decrease the demand, and decrease the erythmogenicity of the infarcted myocardium. So, I will give. What beta blocker I give? Not propranolol or any old conventional thing, but give, metoprolol, carvedilol, nebivolol. These are the newer agents, newer selective beta blockers you use. S inhibitors, ARB must be given, crucial for long-term remodeling, must be delayed until the RV preload is stabilized and systemic hypotension resolves. In the presence of RV infarct and hypotension, hold on for 24 hours, ACE inhibitors. Once the hypotension is corrected, RV preload is stabilized, then you can put them on ACE inhibitors. Which an ACE inhibitor? Ramipril is the best drug as on date available. high-intensity statin, 80 milligrams of atorvastatin, preferably 40 milligrams of rosuvastatin must be started. Now, posterior mechanical catastrophes, posterior medial papillary muscle rupture in a patient of acute infarction, mechanical catastrophes can occur. This is the papillary muscle. Okay, the posterior diagonal artery supplies the papillary muscle. In case of infarct, papillary muscles are infarcted, they rupture, the fragile single vessel supply, catastrophic rupture, and severe MR. A patient who did not have any murmur, at the apex you hear a loud, harsh, holosystolic murmur suggesting that there is a papillary muscle rupture. Or anterior papillary muscle is supplied by the LAD and LCF. This is the anterior papillary muscle. These are the posterior papillary muscles. Posterior papillary muscle is supplied by the posterior diagonal artery. Anterior papillary muscle is supplied by the LAD and LCF. The dual supply rarely ruptures. Rarely we don't have this as well as this affected. At least one of the papillary muscles will be functioning. A suspect immediately in a patient with a recent inferior or myocardial infarction who suddenly developed flash pulmonary edema and a new harsh holosystolic murmur at the apex. This is the posterior medial papillary muscle rupture syndrome. Now, electrical fault, bradyarrhythmias and AV blocks. Type 1, Wenckebach phenomenon, Mobich 1. Type 2, Mobich 2. Anatomy, AV nodal ischemia, RCA nodal branches affected, high vagal tone produces. Or infranodal His-Purkinje system damage implies extensive septal ischemia. So this is, if you know what is Wenckebach and what is Mobich type 1 and type 2, this is not the time to discuss about that. If you don't know it, when we come to the class of conduction defects, you will come to know it. Management, generally benign, transient, responsible to IV atropine, rarely requires spacing. Which one? Type 1 and type 2. Mobich type 1 and type 2. Type 1 is called Wenckebach. High risk of progression to complete heart block is always there. Atropine is ineffective in complete heart block. It may worsen the heart block. Requires immediate transvenous pacing wire insertion. If it is only Mobich type 1 or type 2 or second degree heart block, it responds to atropine. If it is third degree heart block, complete heart block, atropine is ineffective. What you have to do? Transvenous pacing wire insertion must be done. Okay, evidence-based landmark trials and STEMI care. Horizon CAMI trial, complete trial. These are the two landmark trials completed a couple of years ago. Bileveridine versus heparin, G2B3A inhibitors in primary PCI. Bileveridine is the yellow line, blue line here, and the brown line is the heparin plus G2B3A inhibitors. Epciximab, eptifibatide are the G2B3A inhibitors. Guideline established the clinical importance of minimizing bleeding complication and primary PCI to improve 30-day net adverse clinical events. By giving bivalirudine and not heparin plus this one, the mortality is reduced a lot. Major bleeding is very much less when you give bivalirudine and not a combination of heparin and G2B3. This is the Horizons trial. Complete trial, what it said, culprit lesion only PCI versus complete revascularization of non-culprit. This is a study which is comparing, will I treat only the culprit vessel or will I treat all the territories wherever I find the ischemia in the index presentation when he first presents. Now, this PICO trial says complete revascularization is the upper one, the event-free survival, and then complete culprit vessel only PCI is inferior. Directly informed that ESC mandate to perform complete revascularization either during the index procedure or within 45 days. That means you should attempt to completely revascularize the coronary anatomy. Maybe you will take up the culprit vessel in the first instance if there is cardiogenic shock, and then plan the remaining two vessels within the next 45 days. but don't delay beyond 45 days. This is a new teaching. Earlier we were telling you treat the culprit vessel and slowly, electively, you take care of the other vessels. It's not like that. If you do the other vessels also, preferably in the index presentation or within the next 45 days, the survival benefit is much, much more, as you can see in the graph. This complete trial says complete lesion, culprit lesion only is inferior to complete revascularization. So you should always attempt for complete revascularization. Board synthesis, the hemodynamic trap scenario. A 62-year-old male presented with diaphoresis, sweating, blood pressure 85/50, JVP is 4 centimeters above the sternal angle, lungs are clear on auscultation. You see the ECG, L1, L2, AVF, V4R. You can see these leads are showing ST segment elevation, complementary leads are showing ST depression. What is the decision we have to make? What should I do in such a scenario? Board question. Administer sublingual nitroglycerin to relieve ischemia. It is not angina. What it will go? If the pain is there, give morphine. Nitroglycerin is not the first drug. Administer IV furosemide to reduce heart strain. It should not be given because diuretics in this particular scenario in hypotension are contraindicated with elevated GVP. What I should do? I should pump the fluid. A bolus administration of 500 cc of normal saline. Withhold the nitrates. This is the management. Who knows now? 500 cc of bolus N saline is the treatment for myocardial infarction. Do you ever imagine that? You think of nitroglycerin, you think of diuretic, you think of metoprolol, you think of other things. Here, administer bolus 500 cc of N saline and don't give nitrates for the time being because 85/50 is a lower blood pressure. Right ventricular infarction is entirely preload dependent. How do I improve the preload? Venodilatation, nitrates, diuresis also will precipitate fatal cardiogenic shock. So diuretic should not be given, nitrates should not be given because nitrates reduce the vascular tone and produce venodilatation. What I do? Treat with volume expansion. This is a board question. And if you know this, you save many patients of this presentation. Now, the final part. Here is again grounded in the 2013 ACCF and AHA and 2023 European Society of Clinical Practice Cardiology Guidelines. Advanced STE, ST elevation, diagnostics, complex hemodynamics, and rescue. This is beyond the classical pattern. You see, this is the subtle but high-risk patient. With architecture, there is a huge platelet-rich and fibrin-rich coat on the top, and there is a lipid core. The block, this is called the vulnerable block. If the vulnerable block ruptures, there is stuttering, ischemia. The ECG is not a diagnostic with ST elevation. Troponins are fluctuating because the block has ruptured and opened the core contents to the bloodstream. Blood is still flowing. ECG doesn't show classical ST elevation. Now, there is thrombus formation now, platelet aggregation, activation, and then adhesion, aggregation, activation, and aggregation. All the three are happening. All the red cells, fibrin, everything is formed in the fibrin mesh. The white platelets are trapped to form the thrombus there. Vessel is completely occluded. Transmural myocardial infarction, ST segment elevation. The key takeaway is ST elevation requires continuous, complete occlusion. The moment you see ST elevation, it means there is a complete occlusion of the culprit vessel. Stuttering microembolization creates high-risk ACS without classical STMI criteria. That is this picture. It's stuttering ischemia, classical ST elevation is not there. But this microembolization will produce a syndrome which will be very fatal also. So you must be able to diagnose stuttering ischemia, non-diagnostic ECG. Don't send him away. Observe and then look at the troponins, look at the regional wall abnormalities, and transmural ischemia, classical ST elevation. Look at the pathology and the clinical presentation. Stable high-risk architecture is the first picture. Stuttering ischemia, non-diagnostic ECG is the second picture. Transmural ischemia is the third one. Now, redefining ischemic symptoms across high-risk phenotypes. What is a high-risk phenotype? A diabetic fellow, elderly fellow, previous angina, all those things. And male gender and family history of myocardial infarction. Some brother, sister, or father, they suffered before the age of 55. That is a high-risk phenotype. Now, crushing chest pain, ischemic classical male presentation, dyspnea, warning yellow female cohort where they don't have the chest pain but they present with angina equivalents. Sometimes they say very weak, unexplained fatigue, jaw and neck pain, arterial red and elderly diabetic cohorts, and presenting with syncope. Terminology shift, typical, atypical is abandoned, cardiac, possibly cardiac, non-cardiac is today's presentation. Clinical trap, absence of chest pain does not rule out myocardial infarction, particularly in diabetic patients, elderly patients. They delay the first medical contact because diabetic patient, women patient, elderly patient, they do not have a classical chest pain and chest pressure and radiation. So they won't come. They think it is gas trouble or some other trouble, some musculoskeletal thing they will think. So the first medical contact is delayed, door to balloon times also are delayed. Now, as a clinician, you must be very watchful about these types of atypical presentation. The presentation is not atypical chest pain. It is atypical presentation or a rare presentation where the patient comes with not chest pain, but chest pain equivalents. What are the chest pain equivalents? Dyspnea, diaphoresis, breathlessness, unexplained fatigue, jaw and neck pain will be the presentation in diabetics, elderly, and in women patients. Okay. D winter sign, upsloping ST segment depression in 1 to 3 millimeters and at the J point in V1 to V6, tall symmetric peak T waves are there. Reciprocal ST elevation is seen in the AVR. This is a very, very important left main disease. You cannot miss the left main disease. Left main disease means it is the culprit vessel. Culprit is here, LAD and LCX both are blocked. That means a huge part of the myocardium will not get the blood supply. How do I diagnose? Upsloping ST depression. This is ST depression, and the ST depression is upsloping. How much? 1 to 3 millimeters depression, and there will be a J point depression in this is J point. J point depression. V1 to V6. Tall symmetric peak T waves, reciprocal ST elevation in the AVR. Always look for AVR ST elevation. AVR generally is not important lead. But if you have an ST elevation AVR with V1 to V6 peak T waves and J point depression, it is called D winter sign. It suggests left main disease, which is very fatal. This is the so-called widow, widow warning sign. Valence syndrome. What is Valence syndrome? Type A and type B. Occurs during pain-free interval, normal or minimally elevated cardiac enzymes, T inversions in V1 to V3. What is the clinical status? High risk of imminent anterior infarction. And stress testing is strictly contraindicated, requires urgent angio. Valence sign is there is no ST elevation, and during the pain-free interval time, he will have a minimally or normal cardiac enzyme. They are also not elevated. T inversions are seen in the pain-free time. Symmetric cup-shaped T inversions in V2, V3. Don't ignore them. This person will require urgent angiography, and we should not do stress testing because it will precipitate sudden cardiac death, SCD. Okay, Smith's modified criteria to detect ischemia inside the distorted QRS complex. Concordant STE, ST elevation, This is the baseline. This is the peak of the ST, and at least it should be more than 1 millimeter. ST elevation of more than 1 millimeter in leads with a positive QRS. This is a lead with a positive QRS. R wave is there. ST elevation is there. Measure the ST elevation from the base. It must be more than 1 millimeter. This is called the concordant ST elevation. Original Garbosa scale 5 points. Concordant ST depression. This more than 1 millimeter depression in V1 to V3. This is the complementary change. This is the complementary elevation, original elevation in V4, V5 or V6, and complementary depression in the opposite leads of 1 millimeter. This again, Garbosa score 3 points. Look for concordant ST elevation and concordant ST depression. The discordance ratio. What is discordance ratio? Smith's modification. ST by S. This is ST, this is S. This is the S wave, and this is the ST segment. The ST segment elevation is at least more than 25% of this S wave. Replaces the arbitrary 5 millimeter rule. ST elevation of more than 25% of the preceding S wave. Now what I'm doing? I'm comparing the preceding S wave with the ST segment. If the ST segment elevation is more than 25% of the preceding S wave, this is a Smith's modification of discordant ratio. So you have to use either concordant STE plus concordant STD of more than 1 millimeter. This is the Garbosa 5 plus 3, 8 points. Or discordance ratio of Smith modification, where the ST elevation is at least 25% or more compared to the previous S wave. Okay. Global subendocardial ischemia generates an isolated AVR vector. All the leads are normal. AVR is positive, showing no AVR vector. This is a global subendocardial ischemia. Global means entire left ventricle is affected. ST segment elevation of more than 1 millimeter in AVR alone indicates a dominant electrical injury, vector pointing towards the right upper chest lead. Never ignore the AVR. Earlier days we were not focusing on AVR. Now AVR must be looked at. If AVR 1 millimeter ST elevation is there, and reciprocal reality you can see in the other leads, this is a global subendocardial ischemia. Correlates with the left main coronary artery disease occlusion, severe triple vessel disease, or diffuse supply demand match. If I see an AVR ST elevation, three things are possible. One, left main disease. Two, triple vessel disease, or severe supply demand mismatch. So earlier days we are not focusing on AVR. Now AVR must be looked at. Now, refractory pain without classical ST segment elevation demands rapid risk. That means patient is there, you have put him on DAPT double platelet inhibitors, and you also given heparin. You also patient pay nitroglycerin if necessary, and patient pain is not regressing. Patient with refractory ischemic chest pain, ECG doesn't show ST elevation, and what do I do? ECG looks normal. And patient has got refractory chest pain after half an hour also. The pain is not regressing. Then the question is the red sign, is there hemodynamic instability? That means is there acute heart failure or life-threatening electrical disturbance, arrhythmia? Understand the scenario. Patient has presented with chest pain, very much suggestive of cardiac chest pain. ST segment elevation, we could not find out. All other changes which we have described are not there. Pain is not regressing. What do I do? Don't send him home just because the ECG looks without ST elevation. What you have to do? Look for hemodynamic instability. That means, is there acute heart failure? Is there life-threatening arrhythmia? Then what I have to do within 2 hours, cath lab activation, do primary PCI, look at the coronary anatomy and relieve the fluid. No, patient is hemodynamically stable, blood pressure is good, heart rate is good, SpO2 is maintained, patient is not danger of vascular collapse. Then rapid diagnostic layer I have to introduce. What is the rapid diagnostic layer? The delta troponin. The troponin 0 hour, 1 hour, 2 hour, look at the delta troponin. If the delta troponin is getting more and more elevated within the first 2 hours, positive or do a focus. Regional wall motion abnormality, massive increase in the delta, this one immediate invasive angiography. Or the other way around, urgent echocardiogram also we have done, and this one. But there is no delta, the troponin is not increasing, there is no regional wall motion abnormality, non-invasive coronary cardiac imaging you have to. So coronary CT angiography you have to do at that point to see whether there is any occlusion in the vessels. I'll repeat this slide. Very important. A patient has come with classical chest pain, but ECG does not show classical signature changes of ST elevation and reciprocal changes, hyperacute T waves. None of the things we have discussed are there. But he is not responding even after half an hour, 45 minutes of your treatment. Chest pain continues, he is wincing in pain. What you have to do? Look at the hemodynamic instability. Is there acute heart failure? Is there pump failure? Are there life-threatening arrhythmias? Are there? Immediately PCI, cath lab, active invasive strategy. No, patient is stable, blood pressure is all right, systemic circulation is maintained, and then SpO2 is good, heart rate is stable. Then I have to introduce the next level of diagnostic layer. What is that? Look at the delta troponin. Wait for 1 hour. See the delta troponin. Delta is very much raised, invasion. Or do a focus and do an echocardiogram to assess the regional wall motion abnormality. Yeah, there is a wall motion abnormality. Go to invasive angiography. No, this patient pain is not regressing, but then the hemodynamically is stable, and then troponin did not show any increase, delta is not there, and then regional wall motion abnormality is excluded, and all these are ruled out. Then you don't take him to the cath lab. You go for non-invasive imaging, coronary CT angiography, depending on that. Now, STEMI equivalents. What are STEMI equivalents? You must know them. What are they? Triggers posterior MI, AVR ST segment elevation, diffuse STD, and D Winters and Garbosa positive LBBs. These you should not miss. Posterior wall MI you should not miss because it doesn't produce classical presentation. AVR ST segment elevation you have to see. And then look at the STD and ST elevation, 1 millimeter, 1 millimeter. That is the Garbosa's criteria, D Winters criteria, and a positive LBB action. Immediate primary PCA you must go. Okay, door to balloon within 90 or within 120 from the first medical contact. You have to do this. Second one, Minoka. What is Minoka? MI with non-obstructive coronary arteries. That is, he has got MI, but coronary vasculature is normal. Clinical MI, angiography shows less than 50%. The cardiologist said all the vessels are flowing, less than 50% only in the major epicardial vessels. Now, what is that Minoka? Minimal non-obstructive coronary artery disease. Intracoronary imaging, IVS ultrasound, intravascular ultrasound, or OCT to find plaque erosion and plaque rupture missed by the angio. Functional testing, spasm provocation, give acetylcholine, and whether the pain is worsening and ECG changes are appearing. Structural imaging, cardiac MRI, CMRI to differentiate true Minoka from myocarditis or Takotsubo syndrome. So these are the 3 other investigations which you have to see in case of Minoka. What is Minoka? Minimally in myocardial infarction, non-obstructive coronary arteries. What I should do? Intravascular ultrasound or OCT. Functional testing by spasm probe with acetylcholine. Structural imaging using cardiac MRI and differentiated Minoka from myocarditis and the rest. Now, multi-vessel disease management shifts towards complete revascularization. This is what we have already seen in the trial. There is one lesion in the RCA. There is one lesion in the this one, there is a culprit lesion here. The yellow ones are non-culprit. I not only treat this vessel, I should treat all the non-culprit vessels also. Historical approach, previously what we were teaching, treat only the infarct-related artery, IRA, the culprit vessel, leave the non-culprit culprit lesions for medical management and follow. This was the original teaching. Now guidelines have revised. You cannot leave him on medical management and treat only the IRA. IRA is infarct-related artery. Now, current guideline emphasizes treat the IRA on the spot and treat the non-culprit lesions either at the same sitting during the index procedure or if he is hemodynamically unstable as a staged procedure within 45 days. Clinical rationale, complete revascularization is driven by compelling reductions in the long-term major adverse cardiovascular events. This is called MACE. MACE is major adverse cardiovascular event. And repeat urgent revascularization compared to culprit vessel strategy only in STMI patient. What is the take home here? The professor's teaching. STMI patient, you find more than one vessel is affected. You try to treat all the vessels in the index presentation. Open the culprit vessel and treat all the vessels by whatever is the procedure you require to choose. But if it is not possible because of hemodynamic instability, you don't just prescribe medicines and ask him for follow-up. You call him back within the next 15 days, 1 month, within 45 days, treat all the vessels. This is today's teaching. You cannot ignore that because it reduces long-term major adverse coronary outcomes if you follow complete revascularization as opposed to culprit vessel only, IRA, infarct-related artery revascularization in the previous day. Now, thrombotic risk, stent thrombosis can occur because I had patient, he had a stent thrombosis, we had to do a intravascular rotablator we have to use. There is an instrument called rotablator. It goes and then pulverizes the clot and then opens up the vessel. It's a costly procedure. Rotablator itself is around 6 to 7 lakhs. The instrument itself, we have to bring it. So that is called stent thrombosis and reinfarct. Standard DAPT, aspirin, potent ticagrelor or prasugrel over clopidogrel at 0 month. And then bleeding risk you keep assessing. Intracranial GA bleed is there or not, you balance the thrombotic risk with the bleeding risk. It is a question of balancing the thrombotic risk versus the bleeding risk. Strategy A, P2Y switch. If there is a bleeding, de-escalate the ticagrelor or prasugrel to clopidogrel. Suppose there is an increase in bleeding risk. What do? I give the aspirin, all right, and instead of clopidogrel, instead of ticagrelor or prasugrel, I use the clopidogrel. Or strategy de-escalation. Then strategy B, drop aspirin and continue only clopidogrel as monotherapy. That's one alternate. Now, transition to single antiplatelet therapy called SAPT instead of DAPT, double antiplatelet, single antiplatelet for long-term maintenance will be the strategy in a patient who has got more bleeding risk compared to the thrombotic risk. Okay, now what are the 4 pillars you have? Neurohormonal blockade arrests adverse ventricular remodeling. Beta blockers are a must with all the appropriate contraindications. They reduce the sympathetic drive, decrease the wall stress, prevent arrhythmias. ACE inhibitor ARBs, non-negotiable. Block the angiotensin to prevent cardiac fibrosis and lowers the afterload and remodeling. MRA antagonist, aldosterone antagonist, or lepidolone, crucial for LVF less than 40, clinical heart failure, severe collagen deposition, and myocardial fibrosis are antifibrotic also. MRAs, aldosterone, and new drug, SGLT inhibitors. Newest pillar that is added in the 2023 guideline works at the cellular and renal level, shifts the myocardial metabolism, reduces interstitial edema, and drastically lowers heart failure in post-MI hospitalized patients. The 4 pillars you should not forget in the discharge: beta blocker, ACE inhibitor, MRA, SGL2 inhibitors. Now, ventricular septal defect. What can happen if the septum is infarcted and became very thin? It can rupture and produce a ventricular septal defect or VSD. Presents with a harsh new holosystolic murmur across the sternal border. In papillary muscle, at the apex. Here, across the sternal border, along the sternal border, requires surgical or percutaneous closure of the VSD. Sometimes what happens, the left ventricular free wall, that free wall is the outer wall, lateral wall. If that is very thinned out, it can rupture into the pericardium. This is free wall rupture. Cardiac tamponade presents with sudden pulseless electrical activity, PEA, and profound cardiac tamponade physiology. Shear forces or necrotic transmural tissue leads to catastrophic blowout of that part of the myocardium. Immediate surgical rescue is required. So VST and free wall rupture are true dreaded mechanical complications of any infarct. Now, this slide tells you what are the other supports I can give. IA-BP, Impella, VA, ECMO. These are the newer modalities. This slide I will reserve it for you. Study this slide and I will explain you in the next class because these are newer modalities and not easy for you to understand in one go. I will give you a small write-up on IA-BP, Impella, and VA, ECMO as the add-on medicine, add-on mechanical treatment, mechanical circulatory support profiles. This is called the MCS, mechanical circulatory profile. Dictate hemodynamic rescue strategies. What is IA-BP? What is Impella? What is vacuum? It is beyond the scope of today's presentation. I will leave you a PDF and you can read that and you understand better. Now, the shock trial, the culprit vessel, we have already seen. Culprit only, multivessel. If you treat multivessel and not the culprit vessel alone, the survival benefit is much more. Guideline shift in cardiogenic shock, perform the culprit lesion and PCA during the index procedure and postpone the other vessel treatment within the next 45 days. Old belief, only treat the culprit vessel and give medicines for the others. That's the old belief. Complete revascularization is not indicated. Now, what is the high yield board synthesis? Advanced ACS diagnostic, almost like a take home. Must know ECGs, proximal LAD, 1 to 3 millimeters upsloping, tall T waves, acute T waves, AVR ST elevation, Valence criteria, proximal LAD in the pain-free state, and then the biphasic deep inverted T waves, and also isolated AVR ST elevation, diffuse ST depression, left main disease should not be missed. LBB rules, any new onset LBB, you should not brush it off as a left bundle branch block and apply the Garbosa criteria ST by S ratio. That means ST segment elevation is at least 25% of the preceding SV. Shock and MCS matrix, multivessel PCI, culprit vessel only in the index procedure, and VECMO severely increases the left ventricular load. Impella and others we will teach later. Medical treatment, triage, DAPT in we have to give, that is double platelet entered, de-escalate in case of high bleeding risk. HBR is high bleeding risk. In case of high bleeding risk, you de-escalate to clopidogrel or you can go to SAPT, that is single antiplatelet drug. So with this, the presentation is over. I will share the PPT as well as I will share the video also for your consumption. Any questions are there? You can ask now or put it in the group also.